Yes.
Good evening, my teachers and my colleagues. Yes, sir, should I start, sir?
Yeah.
Good evening, my teachers and my colleagues. I'm going to presenting a case of ulcer.
Good evening, Meena ma'am.
Good evening.
Let us start.
56-year-old Hindu illiterate married male residing at Ahmedabad, a laborer belonging to lower socioeconomic class, presented with chief complaint of raw area over right leg since last month. On elaborating origin during progression, patient was relatively alright before 1 month. Then he had history of something bite over right leg anterior aspect, after which patient had complained of itching and he gave history of scratching over it. After 1 day, he had complained of pain, redness and swelling over right leg, for which he went to some local doctor and took some medication. On third day, he noticed blackening of the skin over the anterior aspect of the leg and over the swelling. On fourth day, he presented to emergency room in Civil Hospital Ahmedabad with complaint of pain, swelling, fever and blackened skin over right leg anterior aspect. There was no history of pus discharge. Debridement was done on the day of admission and patient was discharged after a week and was on regular follow-up and dressing.
Say, go back.
Yes, ma'am.
As you have written, started with the history. Where is your chief complaint? Complaint of, before that you have to write down chief complaint, right?
Yes, ma'am.
Complaint of raw area, this is not the way of writing for presentation.
Okay.
Do you got my point?
Yes, ma'am.
So you have to write down chief complaint and then comes the ODP. Okay, continue. Continue.
Past history, patient had history of... Ma'am, am I audible?
Yeah.
Hello?
Yes, Jai, continue.
Patient had history of transfusion of 1 unit of blood before 1 month. Patient is not a known case of hypertension, diabetes, tuberculosis, COPD, asthma, or ischemic heart disease. There is no any non-drug allergy. On elaborating personal history, patient is vegetarian. Patient has adequate appetite and sleep. Bowel and bladder habits are not altered. Patient is a BD smoker since last 15 years, about 2 to 3 BDs per day. General examination. I've taken informed consent of the patient and I've examined the patient in a adequate exposure and daylight. Patient is conscious, cooperative, and work-oriented to time, place, and person. Patient is well built and well nourished. Temperature is normal. Pulse is 88 per minute. BP is 118576 mmHg. There is no pallor, no jaundice, no cyanosis. There is right-sided inguinal lymphadenopathy present, which I'm going to be elaborating in local examination later. Cardiovascular system normal. RS examination normal. Peritoneal examination is normal. Local examination. Inspection. On inspection, approx 20 cm by 12 cm size, irregularly shaped single ulcer present over anterior aspect of the right leg, extend vertically from 2 cm below tibial tuberosity to 5 cm above malleoli. It extends transversely, maximum 6 cm medially and 7 cm laterally from the tibial tuberosity. Floor of the ulcer has pink colored granulation tissue, which is ample in amount. Ulcer has contact bleeding and minimal serous discharge. Ulcer has sloping edge and edge is purple in color towards the floor and white is towards the margin. Margin is well defined and regular. Surrounding skin appears hyperpigmented. There is no edema, no dilated veins, no blackening. Palpation. I have confirmed my inspected findings with the palpation. Size of the ulcer is 21 cm by 14 cm. And it is extended vertically from 1.5 centimeter below tibial tuberosity to 5 centimeter above the malleoli. It extends transversely maximum 7 centimeter medial and 7 centimeter lateral from tibial tuberosity. Tenderness is present over the floor. Ulcer has pink granulation tissue which bleeds on touching. Base is formed by skin of tibia in its middle part and muscles by medially and laterally. Ulcer is not fixed to the underlying bone. Temperature of the surrounding skin is normal. Surrounding skin is non-tender and has normal sensation. Normal pulsation of femoral artery, popliteal artery, anterolateral artery, posterior artery, and dorsalis pedis artery. 1.5 centimeter by 0.5 centimeter size single non-tender from mobile inguinal lymph node is palpable. Normal sensory motor examination of the lower limb. Normal range of movement of the joints. My provisional diagnosis is post-operative healing ulcer over anterior aspect of the right leg.
Okay. Jay, go back to first slide.
Go back to the first slide. Yes.
Okay. So why do you say it is a post-operative? How come?
Sorry, sir.
How does it become a post-operative is a part of diagnosis?
So patient
What
gives.
what do you mean by post-operative ulcer?
Sir, it is iatrogenic traumatic healing ulcer, sir.
So you want to say post-operative iatrogenic traumatic healing ulcer. Remember, it is very, very important. You should be very clear what are you talking. What do you mean by post-operative ulcer?
So ulcer that is made by debridement.
Which book is saying this? Which book did you refer? Saying that after debridement, whatever the ulcer is formed is a post-operative ulcer. Have you referred any book?
Yes, ma'am. I've read. Yes, last. It is not given a post-operative.
It is written as a post-operative ulcer.
No, no, sir.
Which book have you referred?
Yes, last.
Yes, that's December.
Anyway, the point.
Yes.
Now, what point we want to say is there is nothing like a post-operative. So, is there a pre-operative ulcer?
Sorry, sir.
Is there a pre-operative ulcer?
Uh,
So, what is a classification of ulcer? Tell me the classification of ulcer. So, go by book. You should know the classification of ulcer and give a diagnosis accordingly. Basically, there are two: etiopathological classification.
yes,
Do you
sir.
understand? So, what is
Yes,
that?
sir.
Etiological classification.
Sir, it is sir, basically traumatic ulcer.
How did the ulcer develop? There was initially redness. You say there is
Yes,
history
sir.
of something bind. Correct?
Yes, sir.
So how can it be a traumatic ulcer? Traumatic ulcer means because of trauma or because of surgery he has developed. This is not, he has developed it basically because there was scar or eschar or something on the, and that was the inciting agent was something bite, some insect bite.
Yes, yes, sir.
So it starts with insect etiology.
No, so what I want to say, what is classification of ulcer? Tell me the classification of ulcer according to etiology. One, two, three, 4, 5, 6, something like that.
Yes.
So what is
so there are,
classification? Yes?
sir, special ulcers like
No special, pehla general. Special baad mein. Simple classification.
yes, sir. There could be ischemic ulcer.
What is ischemic ulcer?
In case of arterial insufficiency, there is ischemia
So
that
is
leads
it a ischemic ulcer or will you call it differently?
arterial ulcer.
What do you call it?
Arterial ulcer.
Do you know the
Which ulcer it is?
classification of ulcer? Other classification of ulcer?
Hmm?
Any classification of ulcer?
One is Wagner's classification. That is according to
I think, am I audible or not?
depth
Yes,
of
sir.
the
Yes,
ulcer.
sir. You are audible. જય બુક વાંચી છે કે નહીં? Have you read something about ulcer or not? કે તને એમ કે કરી થઈ હશે presentation.
No, sir, I have read, sir.
So what is classification of ulcer? સાહેબે પૂછ્યું, બહુ simple question છે.
I am asking a basic question. So let me give you a hint. There are two types of classification. One is according to etiology, another is according to pathology. Right? The common classification used is non-specific ulcer and specific ulcer. The
Yes.
types of non-specific ulcers are: first is a traumatic, second is a arterial, third is a venous,
Venous.
fourth is a neurological. Specific includes tuberculosis,
Tuberculosis.
right?
Syphilitic ulcer.
Syphilitic, which is not to be mentioned now, lymphogranuloma
Hansen's.
venereum,
Yes.
right? Leprosy.
Hansen's
It
ulcer,
can
yes.
occur two ways. There can be overlapping. A diabetic ulcer can be specific or it can be part of any of above, specifically traumatic, right? And according to pathology, there is a healing ulcer, spreading ulcer, callus or non-healing ulcer. So stay within this, but don't go outside it. Don't use unnecessary new words for creating a problem. So according to you, what is your diagnosis now?
Sir, post-traumatic healing ulcer.
Post-traumatic healing ulcer. I absolutely agree. Suppose this patient has a diabetes, then
So then I would like if the diabetes is a part of a pathology of the ulcer or not. If there is a
what I want to say, understand the question and answer accordingly. If this patient has a diabetes, will your diagnosis change or not?
no, sir.
No, obviously. Do you understand? But the same patient
Yes, sir.
is having neurological complaint, then it may change. Right? Looking at the type of ulcer, what is the age of the patient?
Sir, 57 years.
57-year of patient, not diabetic.
6 years.
No,
56, sir. Yes, sir. Not
56.
hypertension.
56, 36.
Yes, sir.
What is the age?
56,
Again,
sir.
come again. 56, right?
56.
And the area
56, yes.
of 56 or 57 doesn't matter. The point is that looking at your photograph and the ulcer and the site, would you like to put any other differential diagnosis?
No, sir.
No other diagnosis. Do you understand what is tropical ulcer?
Yes,
What
sir.
is tropical ulcer?
Tropical ulcer, it is in the tropical countries like India, Africa. There is a history of something bite or minor trauma that leads to infection, and then there is which burst and there is ulcer formation.
What is the speciality about tropical ulcer? Can you call this as a tropical ulcer or not?
Sorry, sir.
Can you call this as a tropical ulcer, your case?
No, sir.
Why not?
Sir, tropical ulcer are usually non-healing and chronic, and they are having copious cerebral discharge.
So they never heal.
No, sir, but they are, sir, very chronic ulcer.
Who said so? Have you really read it?
Yes, sir.
Don't confuse trophic ulcer with tropical ulcer. Huh?
Yes, sir.
Tropic ulcers, they are never chronic. They are never ever chronic. They are always acute ulcer. They are always healing. They are always in the upper leg and the middle leg, around the knee, very large ulcer, covering the large part of the leg. They are always healing, having a great granulation tissue and following the trivial trauma. The organisms are a tropical type, fusiformis or similar. So for you, I think this is a tropical ulcer. To prove it's very difficult, but you should always keep it in mind. This can very well be a tropical ulcer, especially in the absence of any other associated etiological factor like non-diabetic,
Diabetes or hypertension.
non-vascular,
Yes.
non-hypertensive. And why
No
such a large
hypertension.
ulcer has developed following trivial trauma? That is a typical of tropical ulcer. So understand this point, you should keep it in mind. Apurva, continue, please. You said healing ulcer, right? Why do you say it is
Yes,
healing
sir.
ulcer?
Sir,
Why
on the
do you
floor
say
there
it is
is
healing? Yes.
so the ulcer floor containing healthy granulation tissue, and the edge of this ulcer is sloping.
Mhm.
So what do anything else? Any other feature remaining? Healthy granulation tissue, sloping edge, anything else?
Sir, the discharge of the ulcer,
Minimal discharge.
yes, it is a scanty serous discharge.
Okay. And how do you
Anything else?
define healthy granulation tissue?
Sir, granulation tissue, it is pink in color, which has punctate bleeding on touch, which is painless.
And how does it look?
And with a scanty serous discharge.
Jay,
Sir, pink in color.
am I audible? Am I
Pink
audible?
to reddish in color.
Yeah, yes,
No,
sir, I can hear you.
Okay, Jay, understand. This is a very simplest case.
Yes, sir.
Sir has asked very clear question. What are the features which suggest that patient is having a healing ulcer, right? So make it a habit to start with the history, inspection, palpation, and end. So you should be saying there is no fever, no much of a pain, right? Do you understand? That is also part of, understand, this is how you describe a ulcer, healing ulcer. On inspection, red, healthy or velvety granulation tissue with scanty discharge with sloping margin, no surrounding edema, no redness in the surrounding region. You understand? So same way, I might have missed 1 or 2 points, but this is how you answer any case of healing ulcer, right? Right? Floor, what is floor? What is floor of ulcer?
Hello.
Yes, I am waiting.
The floor is the
floor?
exposed part of the ulcer.
Okay. So what is significance of floor?
So it might contain sorry, don't know.
Huh? And what is base? What is base?
So base is in what the ulcer is lying, sir.
Did you hear Apurva what
It
he
can be
said?
muscle
I could not hear him. What is base? Please come again.
Yeah, Jay, your voice is breaking up.
The am I audible?
Yes.
Yeah.
So base is on what ulcer is lying. It can be a muscle or bone.
Okay, so base is not the part of ulcer. Base is on
Yes,
which
sir.
the muscle lies. You have said here, what is the base of ulcer? It is free, something like that you said.
Shin of the tibia in the middle part.
Yeah, I don't think you have said that. What have you written in your history about base of ulcer? Find out. Let us find out. What did you write down? Next is now. What you have written, ulcer is not fixed to underlying bone. How
Yes, sir.
did you prove it? I would like to know that, because in exam, some examiner may ask you demonstrate this. How will you demonstrate in this ulcer that it is not fixed to bone?
So by pinching the floor
Now
of the ulcer.
this ulcer, your case, we are talking of your case. This is a statement of your patient. How did you find out that this is a common mistake everybody make? Understand what I want to say, that is, whenever the ulcer is very large, it is technically not possible to assess the base. How will you move the ulcer over base in your case? It is practically covering whole leg. If somebody asks you so, don't put all the points simply for the sake of putting it. Here it is impossible to demonstrate the base of ulcer. You understand? You should write down, it is not possible to judge the base of ulcer, but it appears to be a shin of tibia. So that will tell you, the examiner, that yes, you know. The floor is what you see, base you what you assess in palpation,
Palpation.
right? So
Yes.
you should be careful what you write down. Okay. One more point. What I want to ask you is, what is granulation?
So granulation is a newly formed capillaries with fibroblast and intermingled the red blood cells and white blood cells with fibrin covering over it.
Why granulation is so important? Why granulation is so important? You said granulation, I agree, it is a way. What is significance of granulation?
Sir, in a healthy ulcer, sir, granulation is pink, and in case of infected, it might be scanty and
So
pale.
infection gives a granulation pale color?
No, sir, it is uh,
So what is the reason for pink color of granulation? Pink, red, velvety color. What
is
is the
new
color
vascular.
reason?
It's due to new vascularization and RBCs.
RBCs. So if you see pale granulation, it means it is infection?
No, sir, it might be due to the vascular insufficiency.
That means ischemic disease?
Yes, sir.
No. What is the commonest cause of pale granulation tissue?
So in long-standing ulcers, granulation is pale.
No. What is the commonest cause of a pale granulation tissue? You yourself say RBC gives its color. So when it will be pale?
In case of anemia,
The commonest cause is anemia. One, agree. Other cause? Other cause?
so in case of vascular insufficiency like atherosclerosis or Berger's disease,
Forget about atherosclerosis and Berger's. It's altogether different phenomena. There is a, don't harp on that anemia part now. What are the other causes of pale granulation tissue? This is how exam will go. It is not as you have sat down, I will tell history, they will ask, very good, how will you do dressing? Fine, go home. It's not like that. You are supposed
yes,
to
sir.
do in PG each and everything. And every other candidate is going to get ulcer. So what are the causes of pale granulation? One is anemia, absolutely agree. Remember, infection is not the cause. Even a patients of a good, healthy granulation, if you take a swab, you may find an infection. So don't confuse between these two. So what are the other causes of, when will you find pale granulation tissue? Other causes, tell me the causes of pale granulation tissue.
So in case of venous ulcer,
Very good, agreed. Absolutely right. Not venous, better what is a varicose ulcer.
varicose
So what
ulcer,
is the
yes.
reason for pale granulation in that? I agree with you.
So I'm not sure why.
So what is the reason? How will you define non-healing or callus or chronic ulcer?
So ulcer which has a pale granulation tissue and
So why there
with
is a pale
surrounding.
granulation in chronic ulcer? Why there is a pale granulation in chronic ulcer apart from anemia?
Sir, because of chronic inflammation, there is a fibrosis in underlying structures.
So what is happen? What happens? So what are the stages of wound healing? Tell me. What are the stages of wound healing? First chapter of Love and Bailey.
So I've read it, but I.
So which is the first stage? What happens when there is a trauma?
This aggregation
Stage,
of platelets and fibroblasts.
first is known as a stage of inflammation. So what is stage? Remember, this you should know by tip of your tongue. Very basic thing. So first thing is stage of inflammation. That is the first stage. Followed by, somebody has written hematoma. Let me clarify. Hematoma will occur if there is a closed wound. But when it is an ulcer, there is a breach. So hematoma is not. It is the first is a inflammation. So first is a stage of inflammation, followed by stage of granulation. The word comes. Do you understand? So that is a stage of inflammation is the release of chemical as well as cellular inside that, which forms the starting of the process, followed by granulation. Granulation is a newly formed capillaries covered by fibroblast, release of monocyte, round cell, and followed by there is a lattice works of the protein will shut down like a chondroitin sulfate and similarly. So this is a basic you should understand. So in a normal circumstances, stage of inflammation followed by stage of granulation. So if the stage of granulation is arrested due to improper growth, means the patient is having anemia, patient is having hypoproteinemia, dressing is not done properly, and the healing is arrested. So there will be scanty capillary formation, which will be covered by thick fibroblast and layers, giving rise to a typical pale granulation with slimy layer. If it is not cured, it will progress further and patient will ultimately end up with the callus ulcer. So it is the arrest of healing process which give rise to chronic non-healing ulcer. There are so many factors, but the basic principle is arrest of stage of healing leads to development of this. So you understand? So that is a very important when we are talking of ulcer. Because it is very important. The next question will be, how will you convert non-healing ulcer into healing ulcer? And then that will be, you should reverse the whole process and it should restart stage of granulation again. That's why the excision or a scraping or a cutting followed by dressing becomes the mainstay of treatment in a chronic ulcer. The reason is this, that you restart or trigger again granulation process.
Yes.
Right? Okay. अपूर्व पूछो थाकी गयो हूं Okay. So now your diagnosis we accept. So what are the investigation you will do for this patient to confirm your diagnosis in this patient?
I'll do culture sensitivity, the granulation tissue.
So suppose the patient has come to you, you will do straightway culture sensitivity. Why?
To know if there is an infection ongoing or not.
There will be infection. If you take a swab, it will be positive always, irrespective of that.
So local part X-ray to rule out osteomyelitis.
No, we'll discuss more on culture sensitivity. So what are the indication of taking and why you would like to take culture sensitivity?
To know the bacterial load of the ulcer.
What do you mean by that?
So if it is less than 10 raised to 5 per gram of tissue or not.
So why do you want to take culture sensitivity? One is to see the bacterial, or then what? Whenever you say any investigation, you should be very sure what you are talking about. Unmute your audio. It is muted. That's why it is not possible to speak anything. Unmute it.
Ma'am, still it is muted. I can see you speaking, but I can't hear you.
Unmute your audio. Yes.
Yes.
Now it is
speak,
unmuted.
I am audible?
Yeah,
loud and clear.
absolutely, ma'am.
Yes. Now again it is muted. Okay. So I think there is something wrong. Okay. So
Yeah.
why do you want to say culture sensitivity? Suppose this case comes to you in exam, you will go for culture sensitivity first investigation.
No, sir.
So always say whatever in a order you want to describe. So which is the first investigation you would like to do? And if you want to do culture sensitivity, why?
Sir, I'll do complete blood count first.
Okay,
to see
agreed.
the level of
So
hemoglobin.
we have discussed this much. So hemoglobin and complete blood count are the two most important investigation in ulcer. Don't straightway jump to culture sensitivity. Okay, agreed. Local X-ray, which is another important point, you should keep it in mind, right? Apart from other routine investigation, X-ray test is fine. Culture sensitivity, how will it help you?
Sorry, if it has a purulent or seropurulent discharge, then we can know the.
No, but in this.
The point is that if it is a purulent discharge, how the culture sensitivity? Will you give local antibiotic or will you give systemic?
So systemic antibiotic.
Is there any role of local antibiotic?
No, sir.
Why not? What happens?
So I don't know, sir.
So how do you dress this ulcer?
Sir, with Normal saline soap goes.
Okay. You will not, is there any role of local antibiotic?
No, sir.
There are reasons. The first is 3ith, I think, health already said. There is a formation of biofilm and color which prevents the exchange of antibiotics. Second, there are chances the local antibiotic may cause the resistance development. Third, when the ulcer is healing and good granulation in tissue, there is no role of local antibiotic. So, in this case, you have said it is a healing ulcer. So, if at all you want to do culture sensitivity, when will you do it?
Before planning further management.
That is all right. But that is what I am asking. Planning means what planning? Non-specific answer has no value, beta. This is a patient having a healing ulcer. When will you do culture sensitivity? But tell me your plans. You won't say planning means what is the plan?
Sir, split thickness grafting, sir.
Okay, so will you do culture before that? After that, when will you do it?
Sir, before that.
Why? How it does help? How does it help? In other words, any patient having a large ulcer, though looks healing, with having a red granulation, culture sensitivity is taken to rule out the certain type of bacteria which will cause the loss of graft. What is that? I am giving big hint. Which bacteria causes it?
Pseudomonas.
Never Pseudomonas. Never Pseudomonas. Which organism? It is a combination, especially Streptococcus hemolytica, which digests the graft. So you should be very sure that in a particularly large graft, before going for a grafting, you should always take a culture for that reason. Culture sensitivity has a minimum role once the ulcer becomes healing. You understand? It has a role in a spreading ulcer, non-healing ulcer, when surrounding edema is there, surrounding redness is there, and you expect to give a systemic antibiotic, there is a role of culture sensitivity. Here, there is a minimum role of culture sensitivity. Okay? Which other investigation?
Yes, sir.
Any other investigation?
Serum protein.
Okay, serum protein, agreed.
And
what else? So there are certain investigations the examiner may ask you whether to be done or not. One of them is to rule out vascular condition, Doppler. Would you do it or not? Do you understand? In this patient, it is all right, but many of the cases, particularly ulcers at the extremity.
I could not hear.
Am I audible now?
Yes, sir. I can hear you.
Yes, sir.
But I don't think he is not hearing me. Am I audible now?
Yes, sir. Sir, I am. Sir, yes, sir. Yes, sir.
So what I want to say is, in an ulcer, not in this case, it has not by much value, but in most of the extremity ulcers, Doppler should be kept in mind. You understand? Which is very important in some cases, right?
Yes,
Have you mentioned anything about sensation in your examination?
Yes,
What did you mention?
yes, sir. So normal sensory examination. Sensory
What
motor
is that?
examination.
That's what I'm asking. I read it. I'm reading it. What is meaning of that? You say normal.
Surrounding skin.
So where did you look for a sensation?
The surrounding skin of the ulcer.
Surrounding. Or why did you look for a sensation? What is the reason for looking for a? Again, the same thing here. You have chosen a very large ulcer, most unlikely good granulation. So in which ulcer it is very important to look for a granulation? Am I audible or not? I think either you are selectively hearing some things and some things you are leaving out. I don't know. Everybody else is saying I am audible.
Yes, sir. So, I can hear you, sir.
No, yeah. That's just for the point I want to be very clear. Okay.
In case of diabetic ulcer or neuropathic ulcer or trophic ulcer, there is loss of sensation surrounding the ulcer.
Okay. So what is other name of neuropathic or trophic ulcer?
Neurogenic ulcer or bed
that
sore.
is the same. No. What is the characteristic of neurogenic ulcer or neuropathic ulcer? Penetrating or perforating ulcer.
So it is also called penetrating ulcer.
Okay. So what are the characteristics?
Yes, sir. Sir, it is a sponged out edge, and it is a pale glycerin tissue or tendon or bone in the is a floor.
What else? One is agreed. Any other? Anything else? Site. Most important point is the site. So what are the sites which are likely to have a neurogenic ulcer?
Sir, over the site which are more prone to trauma or being under pressure for a long time, like ischial tuberosity or sacrum or greater trochanter or heel or head of metatarsals.
Okay, very good. Right? So there the sensation is very important. You said joint movement. Agreed?
Yes, sir.
So what are the types of joint movement you will look for?
Sir, if the joint movement is stiff or not, that
what is stiff joint movement? This is a very basic question again. Apurva, are you there or not? I am tired now, asking so many questions.
Am I audible now?
Yes, very clear and loud. Yes.
Okay, I have left the and again rejoined it. Okay.
Yes, okay.
Okay.
So what are the types of, again, you have read Estas?
Yes, sir.
They have described joint movement of two types, passive and active. There is nothing like a stiff joint movement. So what is meaning of active joint movement and what is meaning of passive joint?
Active is what patient is doing actively, that is active joint movement.
So the patient is doing actively is active movement?
That's
and you are doing actively is not active movement. Is it like that?
If, no, if I'm examining the patient and I'm...
See, in this patient, if you are examining the knee joint movement, what will then what is the passive movement?
I ask the patient to flex or extend the knee. And if it does, on his own, then it is active movement.
And passive?
If patient is flexing his knee joint, is it active movement or passive movement?
Well, the very simple thing, Jay. Active
Yes,
is
sir.
done by patient, so it is inspected. Passive is
Yes,
done
sir.
by examiner, so it is palpated. The reason for doing a joint movement are twofold. Why would you like to see joint movement? Why would you like to see joint movement? Did you hear me?
Yes, sir.
Huh. So what happens if there is something wrong with the joint movement?
Sir, I don't know, sir.
So why did you see joint movement? Let us say there must be some reason for that. Remember two reasons. One is ulcers may be crossing the joint. Ulcer may be chronic, leading to restricted joint movement, which may be actually passive, which may be restricted, which suggests contracture. Sometimes restricted movement may be because of only active part, where because of the pain, local pain prevents the patient to take joint as a whole level. So one is when the ulcer is crossing the joint, do you understand?
Yes, sir.
Then it may be due to pain or it may be due to contracture. And it is very important to know that when you put a graft or anything, you should be able to see whether it will interfere with the healing or not. What is happening? Lot of disturbance is coming from
Yeah,
where?
somebody's audio is on, sir. I was trying to find out.
So did you understand? So
Yes, sir.
how does the joint movement will affect post-operative?
Sir, in case of STGS, after STGS, we should immobilize the joint
Yes, very good.
to decrease the shearing forces.
Yes, for a proper healing, it is very important to know that. One. Second, if there is already restricted joint movement, if and you can assess during your examination, you may have to be ready for a treatment of restricted joint movement. There might be developing contracture. You can do under anesthesia free movement of whole, or if required, you can simultaneously need to do contracture release also. So assessment, passive as well active joint movement is a very important part of any ulcer examination. And it should be both way, passive as well as active movement are normal. Do you understand? You have
Yes, sir.
written sensory and motor. Which motor movement you have seen?
Of the knee joint, ankle joint, sir.
That is a joint movement. I am talking, you have a motor you have written. If I can see, you have written normal sensory motor examination and normal range of movement of joints. So why motor is important? Again, remember that is for the
In
same
case of
reason. Because the some muscles may be forming the base of
this,
ulcer. So excessive motor action of that muscle again will hinder with the healing. And that's why you decide pre-operatively what type of the complete rest and immobilization will be required in this patient. So that's why we do examination. It is very important. You should understand. Just for the sake of writing, it is not important. If patient is diabetic and having a sensory loss, what will be the typical complaint? What do you call that description?
sir,
Hmm?
sir, I couldn't get your question, sir.
Apurva, did you get it? I think
Yeah, but
what I,
some audio, a little audio problem.
problem is there, I think so. What I ask is, if patient is diabetic and have some sensory anomaly, what will be the typical complaint of patient?
Jay, did you get it now?
Yes, sir. I get the question, sir. I don't know the answer.
Got it? What is why that? Okay, so I can reframe it. Why the diabetic patient develops more infection and ulcers?
Sir, because the patient has a loss of sensation, and he might not know about the travel trauma to the food.
Very good. One is that unaware of trivial trauma and patient
Repeated.
doesn't take care of food. Okay.
Yes, sir.
What
And,
else?
so in case of diabetes, there might be a microangiopathy, which leads to vascular insufficiency
Okay.
in the area. And there is also neuropathy. It might be sensory motor or autonomy.
Yes.
In case of sensory, I sir already said that patient might not know the
Okay,
there is a
agreed.
trauma.
Anything else? Anything else?
And, sir, autonomic neuropathy might lead to decrease most of the skin and
Anything else? Decrease phagocytic activity because of the diabetes, leading to increased risk of infection collectively. So it will be a typical spreading ulcer. How does the diabetes infection grows on the foot? What is a typical history? Remember, there is a difference between arterial disease with diabetes and pure diabetic disease. Both different things. Don't confuse them together. How does it grow? Ideally you should know whether I should ask for staging of diabetic foot. You know that?
no, sir.
Jay, yes or no?
No, sir.
Anybody else?
Diabetic foot classification.
Somebody has written according to depth of the ulcer. So what are those? You should know this. Yes, it is known as a Wegener's classification. There is some other name, two name combined. Wegener's classification starts with callosity and ends up to bone. As simple as that. This is a very basic question. Will be asked in all ulcer cases. So be prepared for that. Right, up to grade 5, it is there. Right. The initial question, I ask a very simple question. How does the patient will describe his or her sensation loss in diabetes? That was the original question.
Patient might say that his slippers or is wearing while walking. He might not know that.
It is a typically known as a glove and stocking type of. That's what I was asking. Answers are always simple, but you should apply yourself. Don't try to find unnecessary deviation. It's a very simple question. It would have been over. So that is the one. Similarly, another question is, once there is a setting of an infection in diabetes, it grows along the tendency. So external appearance, it may be localized, but in the actual circumstances, it grows very deep proximally along the tendency. That is a typical feature of diabetic ulcer. Okay, I agree. This is not a diabetic and everything. It is a classical healing ulcer. Now this is ulcer. What will you do?
So we can plan STSC, sir.
What will you plan?
STSC.
What is STSC?
Split thickness skin grafting.
So why don't you use STG? What is STG?
It's the same, sir. Split thickness skin grafting.
No, but what is meaning of split thickness? What is the thickness here?
Sir, the split thickness skin grafting, we took a part of skin that contains epidermis and superficial part of the dermis.
Superficial part of the. Why split thickness graft?
Sir, it is technically easier procedure.
No. There is Remember, we don't do surgery for technically easy. Is there any other option here?
Sir, this is a very big ulcer. So the site, donor site healing is better in STG.
Is there any other option here? We have only one option, I think so.
Yes, sir.
Right? But why? What is the advantage of STG?
So to cover this large ulcer.
Hmm? What is the advantage of STG? How does
Cover the large
work?
ulcer and you don't need
So the donor site heals on by itself, and it can cover. If we do meshing of the STG, then we can cover up to 6 times of the graph size.
So, what was your answer? Sorry, I had to leave for a. So, how does the STG work?
Sir is asking how does it work?
So there are 3 phases of uptake of the graph, sir.
So, when you put a graph, how does that graph will survive?
So there are 3 stages of uptake of the graph, sir. First is plasmatic imbibition. Second is inosculation, and third is neovascularization.
So, how does it survive? I did not understand your jargon. What happens? And that's why the word split is used. And you should not put a full thickness. So it takes directly nutrition and blood directly from underlying granulation tissue. Very simple thing. So if the graft is thick, chances of rejection are high. So graft should be kept as thin as possible so it can take directly by imbibition nutrition from the underlying cell. Then the second and third stage come and graft is taken up. Right? So whenever there is a very large area and cosmesis is not an issue, STG is the best. Right? Why the cosmetically it is poor?
So after the uptake of graft, there might be contracture or hyperpigmentation over the
contracture and hyperpigmentation. Very good. So these are the 2 reasons you should keep it in mind. So this is a very large area. So from where will you take a graft?
From thigh, anteromedial aspect of the thigh.
So it will be all right.
Sorry, sir.
It will be all right from anteromedial up the same limb, opposite limb.
So either of.
No, there is a difference. Either of you na hoy.
So from the opposite limb.
Will it be all right? It will be okay that it will be sufficient from if you take from opposite?
Yes, sir.
Okay, right. So how do you calculate graft area?
Sir, about 1/4 of the recipient side, 1/4 to 1/6. If we are using a meshing mesher.
Okay, so you are always going to use mesh, right?
If we are
So
using
again,
mesher, then yes, sir.
Then it is fine. It can be up to 2, 4, 6 times than the normal area. But that's why we always measure the ulcer area. and approximately the area of the inner side of thigh is decided. It can be preferably taken from opposite first. If it appears to be insufficient, can be taken from the same thigh also. Suppose that is also insufficient, which are the other area from where you can take STG?
From the arm,
So before arm, the gluteal region is one more region. It is not commonly used, but when the large area of graft is required, gluteal, because it will be a pressure bearing, patient will not be comfortable, but that can also be used. Similarly, the trunk or torso is a very good source of STG harvesting. So in that case, you can take from abdomen and back also. So any that can be useful, but the larger area take, more causes the problem. So measure should be used. Okay. So the patient is waiting for a grafting. Which dressing material you will use in this patient till then?
so paraffin goes over the donor side.
I'm not talking of donor. This is the ulcer. How will you keep ulcer prepared till the grafting is done? Pre-operative dressing of this ulcer.
You are going to graft in 2 days. So how will you dress it? Sir is asking that. Tuesday grafting કરવાનું છે. What will you do now?
So normal saline dressing.
Why normal saline?
So to keep the ulcer moist, and we can also know if there is any discharge.
Acha, so to know the discharge you do with normal saline. Okay, suppose I have a very pet question I always ask everybody. Can you do with the sterile water or no?
So I don't know, sir.
Have you ever tried it or not?
No, sir.
What will, so why you are
So it
using,
might cause,
why you are using normal saline? The word itself is showing the way.
so if we use the sterile water, then it might get edematous, the granulation tissue.
Edematous or dehydrated?
Sir, dehydrated.
No, you are right, edematous. Why? Because the normal water, what will it do? The point is that it should be isotonic. The word is which is used, isotonic solutions are best. Otherwise, either it will cause the local edema or it will shrinkage of the granulation and it will cause more trauma rather than advantage. But remember, the sterile water can be used for a small ulcer for a small time. So it is not to be discarded, but commonly normal saline is used. What is disadvantage of using normal saline?
Sir, I don't know, sir.
અરે હું પૂછવાનું શું પૂછ્યું જ ભૂલી ગયો. અપૂરો શું પૂછ્યું મેં?
Disadvantage of normal saline.
Sterile water.
હા. So it has advantage. So have you done a dressing with normal saline?
Yes, sir.
What happens when you remove that dressing?
Sir, if it is a healthy granulation, then it will have punctate bleeding.
It will stick.
Yes, sir.
So
it will stick.
there are two types. One is a only normal saline dressing. Second is normal. There is a non-sticking dressing over that normal saline, which provides the moistness to that and does not stick and comes out easily without traumatizing the developing granulation or capillaries. So that's the actual question I was asking. So when you are keeping the patient ready for a grafting for a last 2 days, ideally you should cover with non-stick with normal saline. So it will cause the minimum damage to the granulation. So why we do always use it for a long time? Non-stick, I mean crema, liquid paraffin fairly, or a sofratule or similarly. So why we do not use for a long time? what will happen if we use for a longer time? Do you understand my question?
Yes, sir. Sir, I got it.
Okay. So what will happen if you use it for a longer time?
What is the advantage of using paraffin gauze?
Sir, it soothes the granulation tissue and
It protects
there is-
granulation, right? So
Yes,
why
sir.
don't we, as soon as you suppose you decide, oh, this is a good granulation, let us use for a long time. What is wrong for a long time use of paraffin? That is a question.
Sir, I don't know, sir.
Hmm? So somebody has already answered on chat. I think Julie has
Yes,
answered.
yes.
Absolutely right. That is, it will cause the local irritation. They are not isotonic. It causes local irritation and it will stimulate granulation for a long time use, which will lead to what is known as a hypergranulation. So what is hypergranulation?
It is a granulation tissue which is above the level of a normal skin surface.
Uh-huh. So it is good thing. There should be more granulation. It should be all right. Let us have a good granulation that will help us. So why the hypergranulation is not good? What is wrong with too much of hypergranulation?
So, the epithelialization process at the margin
Very good,
will be
very good,
hampered.
excellent. Yes. So you should understand how the ulcer heals.
So, there is ongoing epithelialization at the margin and it will
Yes.
contract.
So if somebody asks you how ulcer heals by two methods, contraction and epithelialization. Contraction occurs from second, epithelialization occurs from periphery. If one of these processes is arrested, patient will go for a chronic non-healing ulcer. So whenever there is a hypergranulation, it hampers with the epithelialization from periphery as well as prevent the contraction. Do you understand? Too much of a fleshy mass, less of a fibroblast can lead to problem. So that's why hypergranulation is not a good thing. So which ulcer you will not graft? Good healing ulcer you will not graft. Anything, any specific thing? It is a healing ulcer ready for grafting, but it may not graft. Why? Don't want to say?
Sir, don't know, sir.
It is a very simple. Which ulcer, which size of ulcer will heal on its own? So when you graft, how many does it take for a healing? If takes up,
Sorry, sir.
how many days will it take for graft to take? When you put a STC,
4
it
to
is
7 days, sir.
10 days to 14 days is ideal. By that time, it will be proper. So any ulcer which heals without graft in 14 days is not a proper for a grafting. Very simple. So what is the rate of ulcer healing? Normal rate of ulcer healing.
So at the
How many
margin,
millimeters per day?
2 mm per day at the margin.
From all side, 1 millimeter from all side. So up to 4 centimeter size of ulcer, if healing, will anyway heal within 10 to 15 days. If you say the rate, do you understand?
Yes,
So
sir.
that's why the smaller ulcer, no need to do grafting, even if they are ready for graft. So where even small ulcer, you will graft. and will not wait for a healing. Again, very simple question. So, how does the ulcer heal? We have already discussed.
So by epithelialization, contraction.
Contraction. So you don't want ulcer to heal with contraction. There you put a graft. The face is the first, where
Yes,
there is a
yes.
good cosmetic. Ulcer which are over the joint or ulcer which are at the vital area should always be graft, either full thickness or split thickness. That itself is a different topic. Do you understand? So that's
Yes, sir.
why it is very important the site of ulcer. Do you understand?
Yes.
What is the role of biopsy in ulcer?
So in chronic non-healing ulcer,
All.
sir, ulcer, chronic non-healing ulcer of venous. So from venous ulcer and
So
ulcer from
all venous ulcer you will do biopsy.
so chronic venous ulcer.
So
And
what are the indication of biopsy in ulcer? It is intraoral ulcer, outside ulcer, everywhere. Even mucosal ulcers are in true sense ulcers.
yes,
So, so when you suspect malignancy,
yes,
right? It can be non-healing, it can be chronic, or even a new ulcer, which has a typical margins, which are, what are those typical margins which make you suspicious that this ulcer needs
so
biopsy?
raised, beaded, or everted.
Yes, cauliflower everted edges, particularly very common in adeno and squamous cell carcinoma. So those ulcers need to be right. Which chronic ulcer may be present for a 6 month or that you need to do biopsy?
So post bunch.
What? Why? Why post bunch?
So there are high chances of developing marginal ulcer. Hello. Hello, sir. Am I audible? Hello. Hello.
Yes. So what did you answer? You said post bunch. Why?
So there are high chances of developing marginal ulcer in that case.
Very good. So any chronic ulcer which failed to heal with adequate things, there can be biopsy is needed. When you need to do excision of ulcer,
So chronic non-healing ulcers. We can
all,
do,
all.
so,
So remember now, the point is that previously we were very liberal in excision. Now we have become less because of the good things. So what are the other methods of dressing which helps in non-healing ulcer? Just name them. 1, 2, 3, 4, something like that.
so collagen dressing.
Very good. Yes. That's it.
Anything else?
Nowadays there are so many. Let me
Any
ask you one.
dressings other?
What is biofilm?
Uh, it is a film made over the floor of the ulcer with
Ap- Apurva? Apurva? Okay. So you should know biofilm. What is biofilm? I will have to leave. Okay. Please continue.
Okay, sir. Yes, sir. So, Jai,
yes, sir.
so what are the various types of new or advanced dressing materials? You said is collagen. Collagen is available in the form of sheet as well as powder form. Any
Yes, sir.
other advanced dressings that you know?
Biological dressings are
Something that will help you in yeah. Okay, what is biological dressing? What are hydrogels?
sorry, sir.
Hydrogels. The new dressings available in cases where you can use it where there is lot of discharge,
Yes, sir.
right?
Yes, sir.
Same way now we have again this vac dressings. You know vacuum assisted dressings,
Yes, sir.
right? So these are we don't need to excise it completely, but at times specifically in chronic ulcers where there is callosity, where the margins are fibrous, you need to cut away the epithelial tissue and clear out to have the granulation tissue,
Yes,
and
sir.
then you can trace it. Otherwise, because of the epithelialization, the healing will not occur. So that is the only indication nowadays for excision of the ulcer. We don't have to completely excise the ulcer.
Yes, sir.
Only you remove the epithelial part and have a good healthy granulation tissue. There are nowadays, again, after dressing ma nathi gaya, but there are dressing materials which are bacteriostatic, some are bactericidal, some are those which help in granulation tissue, like this povidone iodine as well as this paraffin gel. They are all
Yes, sir.
they help in granulation tissue, developing better granulation tissue. There are many more other dressing materials, old and new ones, which can help us in developing better granulation tissue. We have something like oxoferrin. There are many other products which are. Have you used papaya as dressing?
Sir.
Yeah.
No, sir. I have used, sir.
So papaya, specifically kacha papaya, which has large amount of papain enzyme, which is good for as a desloughing agent.
Fluff. Yes, sir.
Yeah. Tell me how about maggots. What do you think about maggots?
So if there are maggots present in the ulcer, sir, we should use
So
a
maggots are, no. My question is whether maggots are beneficial or harmful.
Sir, is a biological dressing.
Yes, they are good.
Yes,
See,
sir.
most of the time, what you feel, what we have seen is that all those ulcers which have got maggots, they develop red granulation tissue very fast because they do not have any slough. The slough has been eaten up by the
Maggots.
maggots, right? What do you do if the patient has maggots? What material do you use?
So turpentine. So it is a
Turpentine to bring it
irritant.
out, right?
Yes, sir.
Yeah, it's an irritant and It will help. Okay, fine. Okay, fine. I think that should be good enough. So I think we have covered almost everything except for some, if you want to go into details of the various types of dressing materials that are available, I think you can go through. But the take-home message from today's lecture would be that don't take ulcer very lightly.
Yes, sir.
They form the basis for your surgical knowledge, right? We see whenever such cases comes in exams, we know that you know all the basic things. So what we try to find knowledge from this type of question. So it is better that you should know each and every part when it comes to something like ulcer or hernia, where we consider that you should be knowing everything, right?
Yes, sir.
I think that should be it. Biju Kasu, any other discussion remaining? I think we have સારા લગભગ બધું જ cover કર્યું છે, and I think we can leave that. Okay.
Thank you, sir.
Any questions on your side?
Sir, I had a question
Okay.
about sir.
Yeah. Bol.
Sir, about STG, sir. If we have taken a STG from a donor side, sir, after how many months we can take another graft from the same side?
At least 3 months. You need complete epithelialization of that area. The dermis has to come. At least 3 months, I would say.
Thank you, sir.
Okay. Chalo, we'll leave then.